Morning, good afternoon, good evening, everyone. Welcome to our session today. As our participants are joining us and coming into the Zoom room, I'm just going to give you an overview of today's agenda and a little bit of housekeeping. So just the next slide, please. So I should say my name is Olive Kokeman with the Network for Improving Quality of Care for Maternal, Newborn and Child Health. We're very pleased today to be able to launch this MPDSR material to support implementation with WHO, UNICEF, with UNFPA colleagues, and with many partners from countries around the world. We have two parts to today's session. In part one, this essential need for robust MPDSR systems will be set out by Dr. Anshu Banerjee, the Director of Maternal, Newborn, Child and Adolescent Health in WHO Geneva. And we will hear from Susan Clappin, a reflection from the FCDO in the UK. What's new about the materials? Dr. Alison Moran will share with us a presentation of the history and what's new and how these are essential moving forward. We will have the country experience from Côte d'Ivoire, their experience of strengthening MPDSR and also the pilot testing of these materials to bring them to fruition to be launched today. And then we will finish up part one with a questions and answers session facilitated by Dr. Ted Babtegifé Haile Gabriel from UNICEF in New York. We move into part two, where we really hear from the countries. We have a great panel from the Ministries of Health, Burkina Faso and Sri Lanka, from the University of Zimbabwe, and from partners in ICM and MCGL, share with us their experiences and how they're going to be using these materials. This component will be facilitated by Dr. Wilczek from UNFPA in New York. And we will have a closing from Ted Bab. Now for the questions and answers session, please type your questions into the chat box. We will curate those and the facilitators will pose the questions to the panelists in turn. And just for the next slide, the final piece of housekeeping, which is quite significant today, because there will be many languages spoken throughout this session. There is interpretation for English, French, and Spanish. Please click on the globe on your Zoom screen to access this. Il y a l'interprétation pour anglais, le français, espagnol. Vous cliquez sur le globe sur votre écran Zoom pour l'accéder. Y en español hay interpretación para inglés, francés y español. Haga clic en el globo terráqueo en la pantalla de Zoom para acceder a esto. So gracias, merci, thank you. All of the materials, the recording, the slides, and the publication will be shared with all the participants that are registered today, and we'll put them on all of our websites. So over to you, Anshu, to please introduce and take us forward. Thank you.
Thank you very much, Olive. And I'm Anshu Banerjee. I'm the Director for the Department for Maternal, Newborn, Child and Adolescent Health and Aging at WHO here in Geneva. And I'd like to welcome you to this webinar that we're organizing together with UNICEF and UNFPA. It's a pleasure to welcome all of you, including all our colleagues from Ministries of Health, from healthcare professional organizations, research institutions, but also particularly from our MPDSR technical working group and other partners. We will go a little bit into setting the scene. I'll set the scene a little bit, and after that, we'll continue with the session. So maybe I can have the first slide. So just to set the context, we know that maternal mortality has declined over the last number of years, but looking at this slide also, we see that we will not be able to achieve most likely the target, the SDG target of achieving a rate of maternal mortality of less than 70 by 2030. The annual rate of decline is also going to be hampered, let's say, by the COVID pandemic, and it will most likely decrease. And in some countries, we even expect most likely that number of maternal mortality cases will increase. So, and further also, we do know that we have around 50% of maternal mortality that this takes place in fragile settings. And this is also the same for newborn mortality. So in these number of countries and sometimes within countries in specific settings, this is where most of the maternal and newborn mortality takes place. And we will need to be able to address that. Next slide. So we do know that quality of care is instrumental in reducing maternal and newborn mortality. and that by improving the quality of care, we could halve maternal mortality and reduce newborn mortality by 58%. And quality of care is not only about the provision of care and having a functional referral system, but it's also about the experience of care and the provision of, for example, respectful care, supported by cross-cutting health systems functions, such as a competent and motivated human resources base, as well as having the right physical resources, such as the right infrastructure and supplies. And of course, all these interact with each other, because if people have a better experience, a more positive experience of their pregnancy, they're also more likely to benefit or to approach health services. So this strengthens each other, let's say, these components. But in order for us to be able to improve the quality of care, we need to know what actually happens. And this is where MPDSR really comes in and will help us understand exactly what went wrong and why during the maternal and perinatal period, when we have a case of maternal mortality or a near miss or a case of newborn mortality. Next slide. So the reason why a robust MPDSR system is so important is really because MPDSR involves qualitative, in-depth investigations of the causes and circumstances surrounding maternal and perinatal deaths. And this process is an integral part of quality of care improvement efforts to reduce maternal deaths as well as preventable stillbirths, of which we also have 2 million every year, and neonatal deaths. And the purpose of MPDSR is really to increase the avoidability of preventable maternal and perinatal mortality by involving all stakeholders in the process of identifying maternal deaths, understanding why they happened, and taking action to prevent similar deaths occurring in the future. Next slide. Just to say a bit more again about the MPDSR process, it really relies on an action cycle of effective identification, of reporting and assigning causes of deaths, identifying actions that may contribute to the prevention of further deaths, also assigning those actions to particular groups or individuals, and looking at timeframes for the completion of those actions, and then to follow up to ensure that those actions have actually taken place. And we know that from evidence that a complex intervention that includes maternal death audits and review, as well as the development of local leadership and training, can lead to a 35% reduction in inpatient mortality, in maternal mortality in district hospitals in low-income countries. So this is really an intervention that's worth investing in and improving. Now, deaths can be reviewed using a number of frameworks, and including, for example, the classical 3 delays framework, which is the delay in seeking appropriate medical healthcare for an obstetric emergency, the delay in reaching the appropriate obstetric facility, and also the delay in receiving adequate care in the facility. Next slide. So the reasons or areas that we feel are important to strengthen MPDSR are, first of all, strengthening routine data systems on maternal and perinatal deaths. This means both identification but also notification. Secondly, also looking at linking it up with existing surveillance systems such as routine health information systems, civil registration and vital statistics. That includes, of course, the birth registration, and also provision of in-depth information on the cause of death. Secondly, is to really strengthen the work of interprofessional teams. It's a responsibility of all healthcare staff, and really what's very important and also being highlighted in the launch of the materials today is the need to work in a blame-free environment. Because if we don't have a blame-free environment, the cases will also not be notified, or they will be wrongly classified in order to avoid blame, let's say. So this is very important. And finally, also, we have identified MPDSR as an essential RMNCH intervention to mitigate the indirect impact of COVID-19 on maternal and perinatal outcomes. And we have been in this pandemic now for 18 months and most likely will be in this pandemic for quite a number of months to come. So it's important that we can really also mitigate the indirect impacts of COVID-19. Next slide. So maybe just to say that it's a pleasure for us today to launch these new materials to improve really the survival and well-being of mothers and newborns through evidence-based and quality of care interventions. Having said that, and hopefully having been able to set the scene, I would now like to introduce Susan Clapham, who is the Health International Development Advisor at the Department of Foreign, Commonwealth and Development Office of the United Kingdom and Great Britain in Northern Ireland. Susan, welcome, and over to you.
Thank you, Dr. Banerjee, and good day to all the participants. Today is an opportunity to reiterate the important commitment that WHO, UNICEF, UNFPA, and the UK's Foreign, Commonwealth and Development Office, the FCDO, have for the well-being of women and their newborns. Today is a time to celebrate policymakers and healthcare professionals, nurses, midwives, doctors, and their multidisciplinary teams for all the hard work that they do for the survival and well-being of mothers and their newborns around the world. Today is a time to call for this review of all probable maternal and perinatal deaths to generate immediate recommendations where possible to help health facilities and communities to prevent similar deaths and to ensure that key messages and information reach people who can make a difference to the survival of women and their newborns. As policymakers, we have the responsibility to protect the lives of millions of women and newborns, as every death matters. This can be much better promoted through up-to-date health information systems, allowing a closer monitoring of the factors which lead to the avoidable causes of death. Today is also the time to ensure a safe and dignified workplace for these healthcare professionals, to provide them with supportive leadership, to invest in their education and training, and to provide a blame-free environment. And finally, to ensure that women and their newborns receive the best possible quality of care. WHO, UNICEF, UNFPA, and FCDO and other organizations have come together today to launch the document MPDSR, Materials to Support Implementation. This report highlights to us step by step, giving us guidance on how to support the process at the district and health facility level as a first step. FCDO was pleased to support the WHO in the development of the MPDSR implementation tools. We appreciate the tools as an important development in advancing our efforts to reduce maternal and perinatal deaths. I'm delighted to be with you today at the launch of the tools, and I really look forward to learning more about these tools. Thank you to all the policy makers and healthcare professionals, community and family members for everything that you do in this very challenging time of the pandemic. And I thank you for your time. Thank you.
We're going to move to the presentation from Côte d'Ivoire, sharing their experiences with pilot testing these materials. And so straight over to you, Didier, Eric, are you ready to take up the mantle? Thank you, Francesca.
Yes, no problem. Bonjour à toutes et à tous, je suis le docteur Eric Didier Ndri, conseiller technique point focal pour la santé de la mère, de l'enfant de l'adolescent et des personnes âgées pour le bureau pays de l'OMS en Côte d'Ivoire. Je m'en vais vous faire l'économie de l'expérience de la Côte d'Ivoire concernant la surveillance des décès maternels et aussi le test pilote des nouveaux outils et guides pour cette surveillance. Slide. Slide, please. Thank you. Alors, le plan qui sera suivi est le suivant. Après une présentation de l'analyse, nous allons vous présenter le test pilote du guide opérationnel, les défis et bien sûr les perspectives. Slide, please. Vous le savez tous déjà, la Côte d'Ivoire est confrontée à un niveau préoccupant de décès maternels avec 617 décès qui est parmi les plus hauts taux en termes de décès maternels au niveau de l'Afrique. Next. En termes d'historique, il faut savoir que c'est en 2015 qu'a été introduit l'audit des décès maternels en Côte d'Ivoire, suivi entre 2013 et 2014 de rencontres de plaidoyer, d'intégration des décès maternels dans le dispositif national de surveillance des maladies à déclaration obligatoire, ensuite de l'intégration dans le paquet minimum d'activités des structures sanitaires et du démarrage effectif en 2014 de la notification au plan national. En 2015, qu'est-ce qui s'est passé? Il y a eu une concrétisation de l'engagement politique à travers un arrêté ministériel qui a porté obligation de notification des cas de décès maternels, institutionnalisant les revues et créant un comité national de surveillance des décès maternels et riposte. Il y a eu aussi, cette même année, la mise en place d'instances de coordination du comité national de surveillance des décès maternels et de riposte et d'un groupe de travail technique. Il y a eu aussi l'organisation du système d'identification et de notification. Entre 2015 et 2019, c'était la phase de mise en œuvre, avec le renforcement des capacités des acteurs dans 20 régions sanitaires et aussi 86 districts sanitaires et hôpitaux de référence, les 5 centres hospitaliers universitaires, l'hôpital militaire d'Abidjan, l'hôpital de la police nationale. Bien sûr, tout cela a été accompagné par de la dotation en matériel informatique pour accompagner la mise en place de ce système. Il y a eu aussi l'introduction de l'enseignement à la surveillance des décès maternels, périnatales et riposte dans le curriculum de formation des médecins en spécialité de gynéco-obstétrique dès 2017 et 2018. Il y a eu aussi un plan de renforcement de la surveillance des décès maternels qui a été élaboré pour la période 2018-2019. Et bien sûr, un arrêté portant création, attribution et organisation du fonctionnement du comité contre la mortalité maternelle, néonatale et infantile. 2020-2021 a été marqué par l'analyse situationnelle que nous allons vous présenter tout à l'heure, avec l'élaboration des rapports de surveillance des décès maternels pour la période 2014-2016 et 2017 et 2020, avec bien sûr une évaluation nationale. Next. Alors, concernant l'analyse de la situation, le but de cette analyse était de fournir une meilleure compréhension du niveau de la mise en œuvre de la surveillance des décès maternels en Côte d'Ivoire, avec comme question de recherche de savoir quel était l'état de la mise en œuvre de la surveillance des décès maternels à différents niveaux de la pyramide sanitaire, y compris les obstacles et les facteurs facilitants de cette mise en œuvre, pour que cette mise en œuvre, bien sûr, soit pérenne et s'inscrive et dure dans le temps. Next. La méthodologie utilisée, ça a été de choisir de manière raisonnée du structure sanitaire, avec bien sûr revue documentaire, analyse de données et l'autorisation fondamentale des comités d'éthique à la fois de l'OMS et de la Côte d'Ivoire. Next. Voici un peu le résumé des résultats que nous avons obtenus. Vous pouvez voir là les 10 centres, les 10 établissements sanitaires qui ont été choisis, qui se retrouvent tous à un niveau assez élevé de de cette analyse situationnelle. Et donc, ces résultats élevés peuvent s'expliquer par le fait que l'outil utilisé donne des scores directement qui vont vers l'institutionnalisation. L'outil n'analyse pas, on n'a pas analysé les établissements en fonction de chaque niveau, ce qui pourrait expliquer bien sûr que les 10 centres choisis aient des scores assez élevés. La deuxième chose, c'est que nous avons choisi, bien sûr, selon la méthodologie raisonnée, des centres qui font déjà la surveillance des décès maternels. Ça peut aussi être le deuxième élément qui explique ces très bons scores que l'on observe en Côte d'Ivoire. Ce qui est bien sûr pour nous une fierté, mais on le verra par la suite qu'il y a des éléments à améliorer. Next. Alors, les scores des hôpitaux varient entre 17,5 et 26,9, okay? Ce qui note de bons scores. Toutefois, les structures de santé visitées sont à la pratique de la stratégie en routine et en phase d'institutionnalisation avec des défis majeurs. L'identification des cas au niveau communautaire, la régularité des réunions de revue des cas de décès maternels, la qualité des informations collectées et la qualité de la revue des cas, l'harmonisation et la classification des causes de décès. On a vu que c'était une grande difficulté. Ces classifications, très souvent, ne correspondaient pas à la classification internationale. Il y a aussi l'analyse et l'utilisation des données, élément fondamental parce que toute revue des décès maternels doit se sanctionner par une riposte, donc par l'utilisation de ces données. Et à ce niveau, on a constaté, cette analyse a permis de mettre en évidence quelques insuffisances. Il y a aussi la mise en œuvre, le partage et le suivi des recommandations. Bon nombre de recommandations sont faites, des recommandations pertinentes, mais qui, dans leur mise en œuvre, sont confrontées à certains obstacles qu'on verra. Next. Next, please. Alors, au niveau des difficultés pour la mise en œuvre, non, please. Turn back. Thank you. Au niveau des difficultés pour la mise en œuvre effective des recommandations issues des revues, les deux éléments majeurs qui sont ressortis de cette analyse sont la disponibilité des produits essentiels, qui revient à 80%, et la disponibilité des ressources financières. Et donc, ces éléments sont des éléments qui vraiment ont freiné la mise en œuvre des recommandations. Next. Alors, on a observé aussi quelques changements. Hein. Alors, quand il s'agit d'assurer l'évacuation des patients dans les délais, on a vu que cette surveillance des décès maternels a permis de mettre à disposition des fiches de référence et contre-référence, de réaliser des staffs en commun, de diffuser les directives. Aujourd'hui, dans la plupart des centres de santé, sont affichées les directives pour une meilleure prise en charge des causes des décès maternels, d'acquérir des ambulances communales. On a le cas de cette politique d'ambulance en pool qui permet de ne pas avoir des ambulances allouées à différents centres de santé, mais d'utiliser de manière communautaire l'ensemble des ambulances qui se retrouvent dans une commune. Il y a aussi la mise en place de flottes de communication pour faciliter justement la communication entre les différents niveaux de la pyramide sanitaire et s'assurer, bien sûr, du transfert de la patiente dans le centre de référence. Au niveau de la réalisation des groupes sanguins au niveau des maternités, ce système a permis de mettre en place des réactifs pour la réalisation du groupe sanguin dans au moins 2 maternités de district. Quant à la réduction des délais pour la prise en charge des patients, la surveillance des décès maternels a permis une implication de tous les personnels en cas d'urgence pour la prise en charge et aussi d'affecter des médecins réanimateurs dans certains districts. Quand il s'agit de la réduction de l'hémorragie du postpartum chez les mères, ce système a permis le renforcement de la surveillance de l'accouchement par les prestataires. Next. Alors, les obstacles et les facteurs facilitants. Au niveau du leadership et de la gouvernance, qu'est-ce qui a facilité? En Côte d'Ivoire, on a vu que la prise d'arrêté de notes circulaires au niveau central et régional et départemental pour la mise en œuvre de la SDMPR a été un élément facilitateur. Par ailleurs, il y a eu aussi le leadership de certaines autorités. On a vu que dans certaines régions, et il a fallu l'implication du préfet de région, qui est la première autorité dans une région, pour que les recommandations soient mises en œuvre. Il y a aussi l'existence d'appuis techniques dans le processus de surveillance d'autres structures en dehors du programme national de la santé de la mère, en l'occurrence l'Institut national d'hygiène publique, la direction de l'information, de l'informatique et de l'information sanitaire, les directions régionales et départementales et bien sûr les partenaires au développement. Cependant, les obstacles observés au leadership, c'est vraiment la non-fonctionnalité des instances. On a des instances, mais malheureusement, elles ont du mal à fonctionner. Il y a la diffusion insuffisante des documents nationaux. On s'est rendu compte que dans certains districts, les acteurs principaux n'avaient pas l'information. La non prise en compte du volet périnatal, la faible appropriation des responsables et l'absence de redevabilité vis-à-vis des actions mises en œuvre. Next. Next. Alors, au niveau... Back, please.
Sorry, Julia.
It's okay. Au niveau de la mise en œuvre, les éléments catalyseurs étaient l'existence de comités techniques de revue, l'engagement du personnel dans la démarche qualité pour améliorer l'offre des services, le renforcement des liens entre les communautés, le partage d'informations. Malheureusement, là, à ce niveau, au niveau de la mise en œuvre, ça a souffert d'inégales répartitions du personnel. Il faut savoir qu'en Côte d'Ivoire et comme dans beaucoup de pays d'ailleurs, il y a des zones où on n'a pas les médecins spécialistes en gynéco-obstétrique ou alors des médecins qui n'ont pas les capacités. D'ailleurs, à ce sujet, la délégation des tâches est en cours de mise en œuvre à travers tout le pays pour essayer d'apporter une réponse à cette inégale répartition. On a aussi noté la faible application des directives, le retard des prestataires et bien sûr d'autres que vous pouvez voir. Next. Au niveau communautaire, le rôle clé des ASC a joué en faveur de la mise en œuvre, l'existence d'un engagement communautaire. Il faut dire qu'il y a un système de remontée de l'information des décès qui surviennent dans la communauté et ça permet vraiment d'assurer une meilleure surveillance. Il y a l'organisation des sensibilisations à travers un réseau de radio en faveur de la santé. Malheureusement, bien sûr, il y a toujours des obstacles parce que les ASC n'étant pas considérés comme ou alors sont considérés comme des volontaires, ne reçoivent pas d'intéressement et ça, c'est une source de démotivation. Next. Concernant le test pilote du guide des outils opérationnels, l'objectif était de recueillir les perceptions des participants sur le guide opérationnel. Next. Alors, pour ce faire, ça a rassemblé 22 personnes venant de divers horizons, de CHU de Boaké, du CHR de Biglo, de l'hôpital de Port-Boué, à travers tout le pays. Et ça s'est passé en 3 jours avec les 2 premiers jours qui ont porté sur l'orientation des participants sur le guide et les outils, y compris des exercices sur des cas fictifs de décès maternel et périnatal. Et le dernier jour, c'était vraiment l'évaluation des documents et le recueil des retours des participants. Next. Alors, dans l'ensemble, la session d'orientation a répondu aux attentes des participants. Next. La durée de la formation et la proportion des travaux par rapport aux présentations, par contre, ont été jugées par les participants insuffisantes. Et donc, ils ont fait comme recommandation d'améliorer le temps pour leur permettre d'assimiler justement tous les contenus de cette formation. Next. Alors, selon les participants, il y a nécessité de plus de temps, comme on l'a dit, mais en particulier pour les sessions suivantes, le suivi et l'analyse des tendances, parce que c'est un élément important pour la prise de décision, l'élaboration des plans d'action pour une meilleure compréhension de comment élaborer un plan efficace et efficient qui puisse être réalisable, et bien sûr, le remplissage des outils pour permettre un remplissage clair et précis dont la lecture est facilitée par la suite. Next. Alors, les participants aussi sur la durée de la formation et la proportion des travaux pratiques par rapport aux présentations, pareil, ça a été jugé par 20% des participants insuffisant. Diapo. Next, please. Alors, selon les participants, il y a aussi besoin d'accorder plus de temps à la définition des cas, à la formation et fonctionnement des comités de revue des décès périnatales, au suivi à l'analyse des tendances. Ça, c'est sur la séquence vraiment surveillance des décès périnatales. Next. Enfin, de manière générale, ce qu'on retient de cette session, c'est que la majorité des participants ont réussi à appliquer efficacement ce qu'ils ont appris au cours des sessions. D'ailleurs, les retours, c'est que certains participants ont déclaré qu'ils se sentaient à même, après la formation, de conduire des exercices de surveillance de décès, de revue et d'audit des décès. Au niveau du guide, plus de 90% des participants affirmaient être d'accord, tout à fait d'accord, que le guide opérationnel les a aidés à appliquer ce qu'ils avaient appris au cours de la formation. Donc, on voit bien que c'est un outil indispensable pour améliorer et mettre en œuvre la surveillance des décès maternels. Next. Alors, au niveau des défis, les défis, c'est vraiment la fonctionnalité des instances. Pour nous, c'est primordial. Nous avons des instances qui se révèlent importantes et pertinentes. Tout reste maintenant dans leur fonctionnalité effective, pas par intermittence, mais vraiment sur toute la durée, de manière pérenne. Il y a aussi le développement d'un plan de mise en œuvre avec des objectifs et des cibles bien définis, y compris un plan de suivi et évaluation, élément fondamental, car un plan de mise en œuvre n'aurait d'importance que s'il est vraiment mis en œuvre et donc si on peut assurer le suivi et l'évaluation. Il y a également la question de la mobilisation des ressources. On a vu dans les obstacles que les finances ont été un élément, une pierre d'achoppement pour la mise en œuvre des recommandations. Il y a l'identification et la notification des cas de décès au niveau communautaire qui a besoin d'être renforcée. Il y a l'harmonisation de la classification des causes des décès maternels selon la classification internationale. Ça aussi, c'est un élément qui est très important pour ne pas se retrouver avec une sous-estimation ou une surestimation des décès. Il y a le renforcement des capacités à l'analyse et à l'utilisation des données et bien sûr la mise en œuvre des actions de riposte sans lesquelles la surveillance serait une surveillance vaine. Next.
Just 30
Alors,
seconds left.
Les prochaines étapes pour nous, c'est vraiment valider, disséminer, aussi assurer le suivi des recommandations de l'analyse, renforcer le plaidoyer à tous les niveaux, avoir un plan de mise en œuvre de ces recommandations, redynamiser les instances et assurer un suivi et évaluation. Par ailleurs, il s'agira pour nous aussi de renforcer les capacités des acteurs avec un focus sur l'analyse des données et la classification des décès maternels. Voilà. Je pense que je vais m'arrêter ici. Next. Et vous dire merci pour votre attention et si vous avez des questions, l'équipe de la Côte d'Ivoire reste à disposition. Thank you very much.
Merci beaucoup, Didier Eric. Thank you so much. And now we go back to Allison's presentation. And at the end of this presentation, we will have questions and answers. So please type your questions in the chat box. Over to you, Allison.
Great, thank you so much. And hopefully this is better sound. Apologies for the technical glitch. But I think this has worked out very well. It was excellent to hear the experience of pilot testing these tools and materials in Côte d'Ivoire from our colleague. Thank you very much. And now I'm just going to talk a little bit about the materials and then we can have some questions and answers, as Olive was saying. So next slide, please. So just as a reminder of what this cycle is of maternal perinatal death surveillance and response, I'm sure you're all quite familiar with this, but the cycle is a continuous action cycle that really starts with identifying all maternal, perinatal, and neonatal deaths, ensuring that those deaths are reported to the appropriate authorities, and then an intensive review both around cause of death and some of the factors all the factors that contributed to that death. And then very importantly, which is new in the MPDSR cycle, is the response piece. So how will those types of issues be addressed to avoid similar deaths in the future? Next slide, please. So this MPDSR process has a long history. It started in 2004 with the launch of the Beyond the Numbers, the Beyond the Numbers guide, which was launched in 2004. And then based on that and trying to really strengthen the response element of looking at audits of maternal and perinatal and newborn deaths, in 2013, we launched the Maternal Death Surveillance and Response Technical Guidance. And a year before that, the WHO application of ICD-10 to deaths during pregnancy and childbirth, or ICD-MM, was launched. So those were two pieces that went together. And then in 2015, we put together a report that looked at the status of implementation of MDSR on the time to respond report. And then there was a realization that we needed to also strengthen the identification review of perinatal deaths and neonatal deaths. So in 2016, we developed and launched the Making Every Baby Count guide, as well as the ICD-PM, which looked at applying the ICD codes to perinatal deaths. So all of these documents have been developed and launched over the last several years. And now today we're launching the materials to support the implementation. Next slide, please. So just to say, MDSR and MPDSR with the perinatal component are both very popular and being implemented in most countries worldwide. So we know from the policy survey that WHO conducted in 2018 and 2019, where we are in this state of policy change and adoption of policies and guidelines to support maternal perinatal death surveillance and response. So you can see from the graph, I won't go through all the details, but of the 155 countries that responded to the survey, the majority of countries, 80 or a little over 80%, have national policies or guidelines or laws in place requiring notification and review of all maternal deaths. In addition, almost 70% of countries globally have a policy or guideline or law in place requiring review of neonatal deaths. However, for reviewing stillbirths, cases that resulted in stillbirths, it's less than 50%. So that really is a gap area we need to try to address. Next slide, please. However, although the majority of countries have adopted policies and for reviewing maternal deaths and many neonatal deaths, as well as progress around reviewing stillbirths, we know there are many gaps and challenges around implementation, many were just highlighted by my colleague from Côte d'Ivoire. And we also know from a variety of ongoing reviews and reports that have been published recently, including the work that was done by the Maternal Child Survival Program in Rwanda, Tanzania, Nigeria, and Zimbabwe. And you see some comments about that in the chat. So we know that there are limitations around the quality of the reviews and coding causes of death, how to really implement and monitor the implementation of recommendations or the response piece, really needing to strengthen linkages between the MPDSR death reviews or the audits and quality improvement processes, as well as ensuring that the data collected through MPDSR systems are linked to routine health information and civil registration vital statistics systems. In addition, as many people have mentioned in the chat, there are other restraints around human and financial resources, government support leadership, training, as well as ensuring a permissive legal framework to reduce occurrences of blame and shame among health providers. We do know there are many enabling factors as well, thanks to a recent review by Mary Kinney and colleagues that really look at the importance of clear support from leadership, staff commitment, regular occurrence of meetings, etc. So as a result, and to try to address these gaps and challenges, the MPDSR Global Technical Working Group decided it was important to develop some materials to really address some of these gaps and challenges and improve the quality of MPDSR implementation and monitoring. Next slide, please. So that's where this idea came from. And as you just heard from my colleague from Côte d'Ivoire, in addition to the development of the materials, they were pilot tested in many countries, and the findings from those pilot tests and situational analyses were really helpful for us in finalizing the document. So as I said, the rationale was to really strengthen the quality of implementation and also think about developing some standardized tools around capacity building or training. And this was really a joint effort among all partners within the technical working group. So you'll hear more from some of those colleagues as we go through the rest of the webinar. And as Susan mentioned in her remarks, the purpose was really to provide step-by-step instructions for how to do this based on what's outlined in the technical guidance materials that I showed earlier in that history timeline. Next slide, please. So the goals of the document are to really establish a framework to look at the burden of deaths, including numbers, but also causes, to help generate information about modifiable factors contributing to deaths and how to prevent those same factors from occurring in the future, to promote confidentiality and a blame-free culture, to provide accountability for results and help decision makers understand the problem for advocacy purposes, and also to provide examples of forms and guidance and resources that can be adapted to the local context, and then to compile this for an evidence base for MPDSR. Next slide, please. So the idea of these materials is for a wide range of different stakeholders. So for clinicians, all participants who provide clinical care, as well as those who participate in review processes, for public health officials and leaders, as well as other stakeholders that are engaged in training, decision-making, using data for decision-making. Next slide, please. So we tried to make the guidance in a really user-friendly manner. It's comprised of 10 different standalone modules. So modules can be used independently or together. And each module follows the same format and provides step-by-step recommendations of how to move forward with the process based on the information that's outlined in those technical guidance materials. In addition, there are links to other resources and tools, as well as a very rich appendix of a variety of different forms that can be used as they are or adapted to the local context. And in addition, and very importantly, the guidance document also includes a variety of different capacity building and training materials that have been developed in collaboration with our partners within the technical working group. So the Maternal Child Survival Program, funded by USAID, has developed a module on training for MDSR, including how to code maternal death. Our colleagues at UNICEF developed some training materials on how to better conduct perinatal audit. And in addition, there's a virtual public health campus on surveillance and response that's been developed as well. And those are all included in the document. Next slide, please. So here's a list of the 10 different modules, as well as the type of materials that are included to support those modules. So I won't go through all of them, but you can see there's quite a variety from how do you get started, how do you establish your committees, how do you conduct potentially integrated maternal and perinatal death reviews. I think as we've seen in the chat box, as well as I saw in some of the slides around the policies that have been adopted, the perinatal piece or the stillbirth piece is still starting to be implemented. It's at a much earlier stage. So really thinking about how to bring that up and make it equal so that we have similar maternal and perinatal reviews happening, as well as looking at how do you really develop recommendations? How do you implement those? And then importantly, as I think there was another question in the chat, how to monitor the implementation. Next slide, please. So I just want to highlight a few things that are new, because you may say, well, this sounds similar to what's already in the technical guidance materials, and it's true. It's really an idea of how to operationalize and implement what's in the existing technical guidance in an easy to follow way. But there are some new templates, and there are new resources, and there are the new capacity building materials. In addition, just to highlight a few other things, how to conduct the joint reviews and how to develop responses that would address both maternal and perinatal mortality. Many of the questions we get from colleagues is, how do you select the cases for perinatal deaths? There are so many perinatal deaths. You cannot review them all in many facilities. So how do you go about selecting them? So we have some suggestions for that. Have some clear guidance on how to develop smart recommendations that can be implementable and time-bound and assigned to specific people to ensure those get done. We have included a MPDSR monitoring framework that includes how do you track the implementation of MPDSR, as well as perhaps some of its outcomes or impacts at national, subnational levels and facility level. How to link MPDSR and quality of care initiatives, and I'll show my last slide will be about some of those potential linkages. And we have actually a policy brief coming out about this shortly in collaboration with the Quality of Care Network. Importantly, MPDSR in humanitarian settings, there's a lot of exciting work going on in fragile settings, or as Dr. Banerjee mentioned, the majority of maternal, perinatal, and neonatal deaths occur. How to overcome the blame culture. And finally, as I mentioned earlier, these really great capacity building and training materials. Next slide, please. And so just as an example of what's something that's new in these materials, so thinking about how you might want to align quality of care and MPDSR across levels of the health system. So if we look at the facility level, at the subnational level, and the different types of working groups or committees that may be working on quality of care and MPDSR, just some really clear guidance on how potentially those could be linked within different contexts and systems. Next slide, please. And I think that's my last slide. So look forward to any comments or questions you might have, and to really working with you all on how we can implement these at country level to really make a difference and improve maternal and perinatal and newborn outcomes. Thank you.
Thank you, Alison, Dr. Banerjee, and also Susan for this enlightening explanation and setting the stage, and also how this implementation guide is developed and what the content is, and also the bigger picture. So the chat box has been really active, but we have prioritized a few questions for the three of you to respond. So the first question for Deirdre is, do you have a monitoring tool to measure the way the guidance is implemented in Côte d'Ivoire? For Alison or Anshu, either of you could respond to the question. To what extent are ministries of health across several countries empowered to ably coordinate several of the implementing partners involving in implementation of MPDSR? This seems to be the recurrent issue and needs to be addressed. And another question for Deirdre also is, how is the strategy financed according to Côte d'Ivoire experience? At the MPDSR stations at hospital level and the supervision funded? Do the teams at the local level benefit from specific motivation? And I don't know who would be able to respond to this, but there is a question regarding the legal framework. So I'll leave, the panelists to decide among yourselves. So the question is, what kind of legal framework are we thinking of? I think staff turnover is one of the important challenges at most health systems. Do you think it is feasible to audit all stillbirths and neonatal deaths? And maybe the last one for Eric, Deirdre, is how is the strategy financed? I think it is a repeated question. So yeah, it is regarding, monitoring tool and financing and implementation in Côte d'Ivoire. And yeah, so if you could respond to this, and we'll see if we have time for more questions. Over to you.
Thank you very much for those questions. Alors, in terms of monitoring tools, let's say that for now, I think this is one of the main challenges. C'est vraiment l'une des difficultés majeures. On va dire qu'on a commencé à même suivre la surveillance des décès maternels. Tout récemment, le dernier rapport de la surveillance des décès maternels 2017-2020 a été élaboré il y a quelques mois. Donc, effectivement, il y a un véritable besoin en termes d'outils de suivi, de suivi évaluation de ce dispositif-là. C'est vrai que tous ces décès notifiés rentrent dans la base de données DHS2 du pays, qui est la plateforme de suivi, de collecte d'informations sanitaires. Et je pense que je l'ai rappelé dans la présentation. Donc, c'est l'un des mécanismes qui est utilisé. On a deux bases de données. Il y a le MAGPI qui se trouve au niveau de l'Institut national d'hygiène publique, qui fait aussi une notification des décès qui surveille, et le DHS2 qui aussi collecte les informations concernant ces décès maternels. Et à la fin, il y a un croisement pour s'assurer que les informations sont correctes. Mais effectivement, il serait aussi intéressant d'avoir un outil de suivi évaluation je vais dire, de la revue de ces cas-là. Collecter combien de revues ont été effectuées par district, quelle en était la qualité. Et à ce niveau, pour l'heure, la Côte d'Ivoire ne dispose pas d'outils, mais je pense que cette plateforme pourrait être le lieu de réfléchir à cette question. Concernant le financement, je pense que l'élément aussi de présentation a mis un point d'honneur sur la difficulté justement du financement. Lorsqu'on a conduit cette activité d'analyse, il est ressorti très clairement que l'un des facteurs limitants, c'était la disponibilité de fonds, pour organiser les enquêtes sur les investigations sur le terrain, quand il y a un retard dans la prise de décision, ou alors le cas a été référé d'un centre périphérique vers le centre de référence, il faut y aller pour pouvoir échanger avec cela. Et donc, ça demande du déplacement, ça demande de la communication, etc. Et là, on s'est rendu compte qu'il y avait des difficultés pour financer. Des difficultés même pour financer les réunions, parce que lorsqu'il y a des réunions, on invite en général tous les acteurs de la périphérie, et donc ça veut dire qu'il faut qu'ils se déplacent, il faut qu'ils se logent, etc. Il faut manger pendant ces réunions. Et donc là aussi, il y a eu, bien sûr, une question de difficulté financière. Par contre, il n'y a pas de motivation. Il n'y a vraiment pas de motivation pécuniaire quant à la conduite de cette activité. J'ai vu une question, si je peux me permettre, de l'engagement des prestataires et le retard. Alors, à ce niveau-là, en fait, la difficulté, c'est qu'on s'est retrouvé à avoir des situations où les prestataires de soins avaient du mal, certains en tout cas, à remonter les cas de décès parce qu'ils se sentaient personnellement impliqués. Et je pense que ça rejoint la préoccupation d'un collègue qui parlait du blâme et de la honte. Effectivement, dans certains cas, les agents de santé se sentant impliqués, se sentant coupables, fautifs, ont du mal à documenter le cas. Bien que dans la conduite des audits des décès, il y a une charte qui est lue, qui fait mention expresse que les audits ne sont pas un tribunal pour juger je vais dire, des actes fautifs des uns et des autres, mais c'est un espace pour comprendre ce qui n'a pas fonctionné et apporter des mesures correctives. Donc, je pense qu'il y a ces éléments un peu émotifs aussi qui rentrent dans la ligne de compte quand on parle de revue des décès maternels. Et nous, lors de la conduite de cette analyse, on a pu voir les atmosphères chargées en émotions lorsque les interviews ont été conduites. Donc, voilà ce que je peux répondre à ces deux préoccupations. Merci à vous.
Thank you, Dider. So if, quickly Alison or Anshu could respond to the remaining two questions quickly.
Thanks, Babi. I'll say something about the question around coordination and the government coordinating the partners. And of course, we hope that every Ministry of Health will have a review committee for maternal mortality set. And our role as partners is really to support the work. We just heard from DDA, for example, there's sometimes not enough support, enough funding for people to attend meetings, etc. But I think what's also very important is that at local level, these reviews are done. The review should be done at the facility level, and then the information should be shared at the national level, to which, let's say, at the national level, there's a quarterly review that takes place to really look at this. But it's really the role of the ministry to coordinate the partners and the role of the partners to support the ministry in doing so.
Great.
Yes, that's true, I'm sure. Alison, okay.
Oh, sorry, Ted Bob, to interrupt you, but yeah, no, thanks. Thanks, Anshu. I was just going to maybe try to address the other questions quickly. There was one question about how are success stories from countries incorporated into the MPDSR materials. And as you saw from Didier's presentation, as well as you'll hear more during the panels, was a lot of the results from the pilot tests were done in countries that have been very successful at implementing MPDSR. So we were really fortunate to have that experience to be able to incorporate those learnings into the materials, as well as the resources and the tools at the end. For example, a lot of the templates that look at how you might set up a terms of reference for your review committee, as well as what's a good review form to look at the DES, have been based on evidence that was pulled together when the technical guidance was developed, as well as experience from the success stories who pilot tested, as well as other countries. And then if I have a moment, Ted Bob, I'd like to just quickly talk about the legal frameworks, because I know there have been lots of questions about that as well. And it's a very good question, and it's really a crucial element that we need to think about how we better strengthen these legal frameworks. So I know as part of the technical working group, we are now undertaking a review of success stories in certain countries of what types of legal frameworks they've developed to be able to protect providers as part of MPDSR, as well as other maternal perinatal death review processes. So we're hoping to be able to use that information to develop some recommendations with the technical working group, and be happy to include that as a module in the future as part of these documents. So certainly be keeping you up to date on that work as it moves forward. But if anyone has any examples they'd like to share, please let us know. We're also updating the time to respond report on MPDSR implementation through 2021 and update to the 2015 report. And so we'd like to include some case studies in that as well about how successful legal frameworks have been established. So look forward to continuing to engage with all of you who are interested in this topic on how we can work together on that. Thanks, Ted Bob.
Thank you, Alison, and thank you also, Anshu and Deidre and Nancy for this really enlightening session. I see still, the chat box active, but I believe, some of the questions or the comments are addressed in Alison's presentation. And for those, the remaining questions, we will try to respond and put it in the network website. So now the second session will start. So I will leave the floor to Anshu. Over to you.
Thank you very much, Ted Bob, and hopefully some of the questions will also be addressed in the next panel discussion. And I would first like to introduce Dr. Willibald Seck, who is the Global Maternal and Newborn Thematic Fund Coordinator at UNFPA, and will be facilitating and moderating the panel discussion. And let me also introduce our panel members. Our panel members are Dr. Kapila Jayaratne, who is the National Program Manager for Maternal and Child Morbidity and Mortality at the Family Health Bureau, Ministry of Health in Sri Lanka. We have Dr. Musa Dajora, who is the Program Manager of Safe Motherhood at the Family Health Department, Ministry of Health in Burkina Faso. Bienvenue. We have Dr. Bremen de Mucio, who is our Regional Maternal Health Advisor at the Pan American Health Organization, or in short, PAHO. We have Professor Stephen Munja, Professor and Researcher of Medicine and Health Sciences at the University of Zimbabwe. Professor Ank de Jonge, who is the representative who represents here the International Confederation of Midwives. And finally, we have Dr. Kusum Thapa, who is the Senior Advisor at JPIGO, working for the MCGL, or for the USAID-funded Momentum Country and Global Leadership Project. So welcome to you, and Will, over to you.
Thank you very much, Anshu, and welcome. And I'm really proud to be facilitating such an esteemed panel group. Just to say, we have 6 panel members, and we have only 3 minutes per panel member. So what we will do after 2 minutes, you will hear a tone. Then it just means you have another minute and to wrap up. So we make sure that everyone can really speak for the 3 minutes, and then we have a good discussion. So with that, I would like to hand over to Dr. Kapila Yajaratne. Please take it away. Thank you.
Okay. Good day to all of you. I'm from Sri Lanka, country, low and middle income country in the Indian subcontinent, with a population of 22 million and a live birth cohort of 320,000. We have 100% hospital deliveries, and we report a maternal mortality rate of 29 per 100,000 live births, and an infant mortality rate of 8, and a stillbirth rate of 6 per 1,000 births. So we have a well-structured maternal death surveillance and response system covering the entire country, both field and hospital levels, more than 40 years in operation, and a perinatal death surveillance and response system. It's a facility-based surveillance system started in the year 2006. That is also covering the entire country. So Sri Lanka is looking forward to achieve ambitious goals with regard to sustainable development goals. So there is a need to reshape existing MPDSR and PDSR in alignment with our SDG activities. So we had a golden opportunity of pilot testing WHO implementation tools for MPDSR in the year 2019. I thank WHO for giving this opportunity. It was a good exercise for us to revisit both our MPDSR and PDSR mechanisms, and there were several issues or gaps identified thanks to this pilot testing, even with the well-structured systems in both areas. So, so we got the inputs from this pilot testing with regard to leadership of the Ministry of Health, and how to reposition MPDSR and PDSR as a key intervention for national health development and achieving the SDGs, and the issues of confidentiality and the maintaining no name, no blame culture, and also the need for more emphasis on PDSR and the limited community engagement, the lack of zero reporting, and the limitations in linkages with the civil death registration systems, and how to strengthen the response part, and the issues in dissemination mechanisms. And the most important factor was the non-alignment with the other quality improvement activities, both at field and hospital levels, and also the need for supervision, monitoring, and evaluation of the both processes. So with that, we have already started many activities as a result of this pilot testing. So we have started revising the formats, and we are now working on a guidance to for all the people who are involved in the MPDSR and PDSR in hospital and field level to suit into local context, and in promoting no name, no blame, and no shame culture through mentoring and open communication. And we are developing a meeting code of practice for this, and we have taken several steps to align the MDSR and PDSR as a quality improvement initiative in the facility sector, hospital sector.
Sorry, Dr. Jaradne, we have to wrap up. If you could wrap up, that would be nice, because we already over there. Thank you.
So thank you. We are introducing monitoring framework for both MDSR and PDSR, and I am happy to inform that WHO CRO in partnership with GIFIGO, we train 6 people, experts in MDSR, and WHO country office is now supporting us to implement this initiative in the next biennium. Thank you so much.
Thank you so much, Dr. Jaradne. I'm really apologizing already in advance if I interrupt. We just have to keep the time. It's so interesting and so great to hear how this is being implemented at the country level. Thanks so much. And I think there was some echo, but the organizers are working on that. Next, I would like to invite Dr. Moussa Dajouari from Burkina Faso. Please come in.
Okay, merci beaucoup. Le Burkina Faso est... Il y a un écho.
Please go ahead, we can hear you.
Ok, d'accord, merci beaucoup. Juste pour dire que le Burkina Faso est situé au cœur de l'Afrique de l'Ouest, avec une mortalité maternelle de 300 décès par 1000 naissances vivantes et 23 décès néonatales pour 1000 naissances vivantes. Alors, au niveau du Burkina, nous avons commencé la surveillance des décès maternels néonatales, la riposte, à partir du 1er janvier 2012, en institution, c'est-à-dire dans les formations sanitaires, que dans la communauté. Donc, la notification, elle est hebdomadaire pour toutes les formations sanitaires du pays. Toutefois, nous n'avions pas inclus les morts naissances. Et dans tous les hôpitaux, que ce soit de district ou les hôpitaux régionaux et les hôpitaux nationaux, il y a des comités d'audit. Le seul souci, c'est que la fonctionnalité de ces comités est assez faible. Alors, par rapport à l'utilisation du guide, quelle est notre expérience? Il faut dire que nous avons tenu un atelier. On a réuni les sociétés savantes, c'est-à-dire les gynécologues, les pédiatres, les médecins de santé publique, les prestataires, les gestionnaires de programmes. Et il y a eu d'abord une orientation avant le test, proprement dit. Donc, disons que c'était une forme de formation, en tout cas une mise à niveau de tout ce qui était à l'atelier. Il y avait des cas qui avaient été prévus lors du test, mais les prestataires, c'est-à-dire les gynécologues, les pédiatres, ont apporté aussi d'autres cas sur lesquels on allait se baser pour faire le test. À l'issue du test, il y a eu également des interviews, que ce soit les premiers responsables du ministère, les directeurs centraux également du ministère, les directeurs généraux des hôpitaux. Il ressort de notre expérience d'utilisation que le nouveau guide opérationnel et les outils également constituent un véritable instrument d'intégration de la surveillance et en mortalité maternelle et périnatale. Donc, ces outils sont très pratiques et permettent la prise en compte des morts-naissances, comme je le disais, on ne le prenait pas en compte, et des décès périnataux pour lesquels les prestataires avaient des difficultés à auditer. Le guide aide également à analyser les informations, à adapter la meilleure demande dans la résolution des problèmes et donc à élaborer des recommandations de qualité et la mise en place des changements. Pour améliorer la mise en œuvre des recommandations, il a été suggéré au niveau du Burkina, on met en place un processus d'amélioration de la qualité sur les sites ainsi qu'un comité conjoint multidisciplinaire pour la réalisation des audits des décès maternels et périnatales. Donc, cette amélioration va nécessiter un renforcement de la qualité des soins, de la sécurité des patients, l'utilisation des outils d'analyse, l'instauration du système de motivation. Alors, pour les perspectives, qu'est-ce que nous avons prévu après le test? Donc, c'est d'élaborer des directives nationales sur la surveillance du décès maternel et périnatal, ainsi que la riposte. Donc, l'élaboration de cette directive est en cours. Donc, actuellement, nous sommes au 4e jour de l'élaboration. C'est de mettre également en place un comité national pour la surveillance des décès maternels et périnatales. Il faut dire qu'au niveau national, nous avons un comité de suivi de la mise en œuvre de tous les programmes de réduction de la mortalité nationale, présidé par la Première Dame. Nous allons donc harmoniser la définition des morts-naissances parce que depuis lors, nous étions par rapport aux morts-naissances, des décès de fœtus survenus entre la 28e semaine et les 7 premiers, non, et les 28 jours après la naissance. Maintenant, on a ramené à 7 jours après la naissance pour être en conformité avec les recommandations de l'OMS. Nous allons réviser nos outils de collecte, élaborer un formulaire unique pour les audits des décès maternels, des décès néonatals et les morts-naissances, et élaborer également de nouveaux modules de formation sur la SDMPR pour prendre en compte la nouveauté, diffuser ces directives et les modules de formation, former les membres des comités d'audit régionaux et mettre en œuvre la surveillance des décès maternels périnatales, documenter et partager les bonnes pratiques. Voilà, je vous remercie.
Dr. Johari, we just have to wrap up. If you can come to wrap up the webinar. Thank you. Oh, sorry, I did not want to cut you. If you want to say something, please go ahead. Just to wrap up.
Merci, j'en ai fini.
Oh, merci beaucoup. Thank you so much. Very interesting to hear also that you have advocacy involving the First Lady and some, I think, very interesting elaborations, and I hope we can address them also in the question and answers. Next, I would like to hand over to Dr. Bremen de Musio from PAHO. Dr. Musio, please go ahead. Dr. Musio, are you on or?
Yes, I'm connected, but I can't
Perfect.
open my micro.
We can hear you.
Greetings from the American regions, but my explanation, my talk will continue in Spanish.
Okay.
Hablemos de la relevancia de estos documentos del manual de implementación. Desde nuestro punto de vista son sumamente útiles y yo voy a destacar dos razones. La primera es que se trata de un manual eminentemente práctico que da orientaciones útiles y claras de cómo organizar una estructura operativa de comités que vigilen y respondan a la mortalidad materna, bajando a tierra algunos conceptos que podrían ser bastante abstractos, y eso es de extrema utilidad. El otro punto es que hace mucho énfasis sobre lo que tiene que ver con la respuesta, que es uno de los temas más débiles en la región de las Américas, al menos. En segundo lugar, promueve distintos enfoques de abordaje que se adaptan a diferentes escenarios. Escenarios de alta mortalidad, de baja mortalidad, donde en algunos casos los grupos que analizan la muerte materna y la perinatal pueden trabajar por separado y en otros pueden trabajar en forma conjunta. Incluso en algunos escenarios de baja mortalidad se estimula el trabajo del abordaje del near miss materno como otra forma de estudiar qué es lo que está pasando. Ahora, ¿qué es lo que está pasando en los países de América Latina y el Caribe? Antes de la pandemia hicimos desde la OPS una consulta en 10 de los 11 países con mayor mortalidad materna sobre la situación de sus comités de mortalidad materna, y encontramos que en 5 de esos 10 países los comités nacionales no estaban funcionando. 2 funcionaban irregularmente y en 3 el funcionamiento era considerado normal. Como ustedes entenderán, esto es un punto clave a la hora de hablar de la implementación de estos materiales, porque aunque desde OMS, OPS y otros socios promovamos la difusión y entrenemos específicamente profesionales en el uso del manual, es altamente probable que al menos en esos 5 países donde hoy no están funcionando los comités nacionales, la situación no vaya cambiando. Y si esto ocurría antes de la pandemia, imaginen lo precaria que es la situación actual, donde muchos países ya dejaron de funcionar los comités de mortalidad materna, y eso a principios del año 2020. Hoy en día ese problema se ha agudizado. Ahora pasemos al último punto que me pidieron que hablara, que tiene que ver cómo pensamos en la implementación de estos materiales. Y yo creo que para conseguir la implementación de la vigilancia y respuesta a la mortalidad materna, no alcanza con difundir exclusivamente este manual ni otros documentos, ni siquiera alcanza con que nos dediquemos a construir capacidades locales, aunque no hay dudas que estos 2 pasos son fundamentales para tenerlos presentes a la hora de implementar. El pasado año intentamos definir cuáles eran las barreras y facilitadores para implementar un sistema exitoso de vigilancia y respuesta a la mortalidad materna y al niarmismo materno en varios países de América Latina. Entrevistamos profesionales de países con buena vigilancia y de otros que no tenían tan buen suceso. Y es interesante destacar que la mayoría de los entrevistados mencionó que el factor clave para conseguir que efectivamente se lograra la implementación o que no se lograra fue la presencia o ausencia de la voluntad política de los actores nacionales, gobierno u otros actores. Y también señalaron que era fundamental el liderazgo. O sea que si no conseguimos abogar para que los niveles nacionales trabajen en lo que tiene que ser tomar ese liderazgo, va a ser muy difícil que logremos la implementación y el éxito, más allá de que trabajemos con nuestros socios y que convoquemos a las sociedades científicas. Y un punto fundamental para terminar, que nosotros consideramos que es clave, es tratar de involucrar a las comunidades en estos procesos. Sin las comunidades que son capaces de ser testigos de lo que está pasando, tratar de incrementar la demanda por la claridad de estos procesos, no vamos a lograr tener un éxito en el proceso que queremos implementar. Muchas gracias.
Thank you, Dr. Muscio. And you addressed COVID, of course, that has a major impact on MPDSR, but then also leadership and community engagement. I think all very important points that will help to bring this guidance to implementation. Professor Stephen Mujanja from Zimbabwe is next. Please take the floor, Professor Mujanja.
Thank you, Chairperson. Zimbabwe held a pilot review meeting of the new MPDSR operational guidance and tools in November 2020. And this showed that our practices would have to be improved in several areas to meet the standard that is expected. Our MPDSR committees are not properly set up or recognized as entities within hospital structures to implement recommendations. An improved template should be created with terms of reference that enable it to wield the same power as the other more established hospital committees, such as the Infection Control Committee or Quality Improvement Committee. The second lesson learned was that the data collection recommended by the new guidance enabled the MPDSR process to derive indicators, perform perinatal death review using ICD-PM, and conduct maternal death review using ICD-MM. We now propose to collect data in future using a minimum set of perinatal indicators in order to be able to report monthly the stillbirth rate and the perinatal mortality rate and early neonatal death rate. Maternal deaths will have to be identified more comprehensively with an entire set of all the records pertaining to the pregnancy. A permanent read-only digital file should be created soon after the death of the woman. This file will be held on the computer of the most senior medical officer at the institution in a password-protected folder. And the legal authorities and the MPDSR committee would have to access this file through the senior medical officer. The third lesson that was learned was that good committee governance is essential for the success of the process. Meetings must be properly constituted. Minutes should be taken either during the meeting or soon afterwards. And activities should be followed up by designated people. Committees should, as far as possible, identify actions which health workers can correct within the current constraints. So these and other issues are being addressed in an update with existing guidelines using the MPDSR new guidance and tools. Dissemination is intended to take place during the quarterly meetings in every province in 2022. Thank you.
Thank you very much, Mujanja, for bringing up the 3 points that are very important, and also show how we have to implement. And it's one example how implementation can work on the ground. And now I would like to hand over to Professor Ankte Jonge from ICM, from the Confederation of Midwives.
Thank you very much. All women who are having a baby and their families deserve respectful care based on the latest evidence on what works and what doesn't in maternal and newborn care. And the International Confederation of Midwives, the ICM, has therefore participated wholeheartedly in the various subgroups to develop these MPDSR materials that help to improve care. ICM includes 143 member associations representing 124 countries across every continent in the world. ICM will use these contexts to disseminate the materials to professional midwifery organizations and through them to midwives and nurse midwives on the working floor. And we are particularly pleased with the new module that Alison Moran presented on the blame culture. Providing respectful care to women and babies cannot be done without health professionals involved being treated with respect as well. When a maternal or perinatal death occurs, this is extremely sad, first of all for the family involved, but also for the health professionals. Midwives and nurse midwives are in the front line of providing maternal and newborn care. And too often, the finger is pointed at these healthcare workers if something goes wrong. However, the causes of death are often multi-pronged. There may be a lack of knowledge and skills, but there may also be, as we heard previously, a lack of resources and staff, logistical and organizational problems that need to be addressed. And the new module shows that MPDSR can be used by healthcare workers, policymakers, and members of the community as a resource for learning and improving care, not for blaming people. And the module is very much in line with ICM's tools on respectful care. I think Dr. Banerjee mentioned this. Many women experience abuse, neglect, and condescending treatments in childbirth. And therefore, the ICM has developed tools to promote respectful care. However, in these tools too, the emphasis is on learning to give respectful care without blaming healthcare workers for not doing it. The module on blame culture of the MPDSR materials comprises 10 key strategies. For example, one of them is create and advocate for an enabling environment for implementation of MPDSR with no name, no blame, and no shame, including an overall organizational culture of learning, accountability, and transparency. This is very important. It emphasizes the need to work as a team on the basis of trust and to create a respectful atmosphere in which people can learn. Therefore, the ICM is very pleased to promote the use of these materials. EU should lead to safer and better maternal and newborn care. Thank you.
Thank you very much, Professor Jonge. And I think it also the blame and shame and blame culture is really important to be addressed. And that's why I think we also need to work as teams, and the teams have to come together also with the managers. Everyone has to work together without having that fear, for sure. And last but not least, Dr. Kusum Thapa from Jupaigo, can I ask you to take the floor? Thank you.
Thank you so much, Will. Good morning, good afternoon, and good evening, everyone. One of the main focus of USAID's Momentum Country and Global Leadership, MCGL, is to contribute to global technical leadership and learning by supporting globally endorsed initiatives, strategies, frameworks, and guidelines. Let me start by giving you a brief background of MPDSR capacity building materials and how it relates to the implementation guide. And I have been monitoring the chat box, and I'm seeing there are questions around the capacity building. So while comprehensive capacity building packages for in-person MDSR and PDSR exist, and Alison has already alluded to earlier, a combined global resource to build managers and health workers skill to implement comprehensive MPDSR in process in low resource setting did not exist. So in order to address this gap, MCGL, in collaboration with WHO, UNICEF, UNFPA, along with the Global Technical Working Group, developed a combined MPDSR package. In response to the COVID-19 pandemic, it was further essential to adapt these materials to a virtual background, a virtual platform, which we finally did. The implementation guide, which we've just heard about, is the key reference material for both facilitators and participants of this training. The modules of the implementation guide is an integral part of the capacity building package, and deliberate efforts have been made to use these modules in various sessions and as well as part of the home assignment for the learners. In the last 1 year, using these materials in a virtual platform and in collaboration with WHO, UNICEF, UNFPA, and the Asia Oceanic Federation of Obstetricians and Gynecologists, we have trained 90 participants from ministries, professional organizations, and when I say professional organizations, it's the OBs, the pediatricians, as well as the midwifery societies. Academicians and UN agencies, and reached 20 countries, 10 in the Southeast Asia region, 4 in the Western Pacific region, and 6 in the African region of WHO. As you all know, these are countries where a significant proportion of the world population lives and where maternal and perinatal mortality is moderate to high. We've also prepared a pool of 19 facilitators who can cascade this training in their own countries and across the region. And we've been using these facilitators to cascade the training even in different countries. These materials will be further translated in other languages like the Spanish, French, and countries can then also translate it in their local language. However, as Anshu mentioned, we know that capacity building is not a silver bullet, and it takes a systems approach to really make any meaningful changes. To be most effective, these capacity building efforts need to be linked with the broader QI initiatives. Modules of the implementation guide related to this, and which Alison has really shown us earlier, is also part of the capacity building materials and helps reinforce this concept. Finally, I would like to highlight that integrating the implementation guide as part of the capacity building package is a very cost-effective and a quick way to disseminate these materials across the globe. Thank you.
Thank you so much, Dr. Thapa. And this, I think it was a wealth of information and confirmation how important MPDSR is and how important implementation is, and that a guideline, that the one that we're launching, has probably no impact if we don't think about implementation. That's why this panel was so important. Thank you all for sharing. We have now 7 minutes for Q&A, and I have 2 questions that I want to pose. The first is to Burkina Faso, and I pose the question first in English and then in Francais. What is it planned for the insecure regions in Burkina? Do we plan to implement MPDSR at these levels? And in French, qu'est-ce qui est prévu pour les régions d'insécurité au Burkina? Comptez-vous implémenter le MPDSR à ces niveaux? And I would like to ask Miss Dr. Johari from Burkina Faso to respond to that, if you can. Please go ahead.
Okay, merci beaucoup. Il faut dire qu'au niveau du Burkina, la surveillance se fait dans toutes les formations sanitaires. Et également, la notification se fait également au niveau communautaire. Donc, nous avons des agents de santé à base communautaire qui font la notification des infirmiers chefs de poste dont ils relèvent. Nous avons au niveau des zones d'insécurité, les ASPC qui continuent de travailler, puisque les ASPC sont des agents de santé à base communautaire, sont originaires des villages, donc ils ne sont pas très concernés par le terrorisme, donc ils continuent de notifier. Comme je le disais aussi, nous sommes en train d'élaborer nos directives, puisque nous avions déjà des documents, mais qui ne prenaient pas en compte les morts de naissance. Donc, à la suite de la mise à niveau faite par l'OMS, nous allons donc finaliser nos directives et mettre en place également un comité national de suivi de la mise en œuvre de la SDP. Voilà, merci beaucoup.
Great, thank you. Thank you very much for also it is certainly more difficult to go to the insecure areas, but I think the efforts that you make are showing that it is possible, but we also have to think about it more closely as we have more conflict around the globe, as we see also in the news every day. So I think the question is very important, and thank you for giving the perspective from Burkina Faso. It's certainly an area that we will have to work on more in the future. And then the second question that we have is, how can health professionals become advocates against the blame culture? At the moment, health professionals are more on the receiving end of the blame, but how can we make sure that they're more included? And Professor Anke Jongai from ICM, can you maybe elaborate on this a little bit?
Thank you. That's a very important question. I don't have the answer. I think we have to work on this together. But my idea is that I think very often the people working on the working floor are not so involved in MPDSR. Were not so involved before. So I think it's important to include them in all levels when we define the protocols, when we select the cases, so that they're involved in the whole process, and there is less of a us and them culture. So that's the second thing. I think, as somebody mentioned before, and I mentioned too, it's important people start working as a team, and that probably means in many settings that we need to break through the hierarchies somewhat. That sometimes prevents this from happening. And again, I think if you include all levels of care in MPDSR endeavors, that may help to break that a little bit and gain more respect for each other.
Thank you. Yes, and I guess it's not only is the hierarchy at the health facility level, pediatricians, obstetricians, nurses, midwives, but also at the managerial level.
That's right.
Yeah. I think that's hopefully will change even more. And we have time for a third question, and the third question goes to Sri Lanka. And there was just a clarification question, whether the emphasis of MPDSR in Sri Lanka is only on assisted delivery by qualified personnel, or is it in health facilities in general, and whether the modules have been adapted or into the national context before. And I was wondering whether Dr. Jararatne can respond to that.
Yeah. Can you little elaborate on the question?
Yeah, the first part of the question was, is the MPDSR only focusing on healthcare professionals who are like skilled birth attendants, or is it focusing on health on the health facility in general? And the second was whether you had adapted international guidelines to the national context, or whether you had to adapt it, or how much you had to adapt.
Yeah, actually, in our setup, we have two separate programs, MDSR and PDSR. In both situations, we have all the healthcare workers, all the spectrum of healthcare workers involved in the process, especially in maternal deaths. We start from the registration of the woman eligible as an eligible family up to the time of death. So all those who were involved in the management of the index case is involved, and so again, not putting the blame on, not finger pointing. So in the PDSR, so it is more or less facility based because our numbers are very much low. So maternal deaths only 90 cases, and in hospital also stillbirths or perinatal deaths, it comes to about 5-10. I mean, majority. So we have adapted our system. Both systems have been in place more than 20 years. So over the years, we modified these tools, taking all the inputs from international level, global level, and also adapting to the local context. So ours is a different system because now in almost all cases we do postmortems and all. So so the data flow and the what variables we are taking on are a little different from the international level, because ours is a unique system, but we always get inputs, and from this MPDSR pilot project also we learned a lot, and now we are translating what we learned into practice.
Great, thank you so much. And so local adaptation, I think, is key, and I think you just confirmed that. So the question is answered, yes. And I think we have to encourage everyone to look at the guidance as something that has to be locally adapted. And that's why I think it has also been written up flexible enough. I have indication from our organizers that I have to wrap up this session. It's so interesting to hear from all of you the questions, but also from the panelists. I'm not so happy of closing this now because I think there will be more questions, but in any case, I think we have to close. Everything is recorded. If you want to listen to it again, you can, and it will be posted on the internet. And with this, I hand over to Tetbab for the closing remarks, I guess. Thank you.
Thank you, Will, for this lively discussion. It was really very informative, and I hope the participants have gained some context and perspective from this country. Next slide, please. So in my last summary of the session would be, all what the panelists in the country experience have presented, and also what we could summarize from this implementation guide are, these few bullet points you see here. There needs to be, an effort to identify, notify all maternal perinatal diseases, and including, linkaging to the health information system and CRVs. I think COVID has shown us that we have no excuse. We cannot say, because the perinatal diseases are too many, we cannot report, because we have shown in COVID to report over 200 million COVID cases to WHO. And compared to that, it would be a fraction of that. Second, we need to strengthen the capacity and to improve documentation of causes. And we have shown, the tools and how to do cause identification and cause assignment for newborn days and stillbirths, with the objective to avoid preventable diseases in the future within mothers and children. The other point we would like to make, a note, and we hope, this would be a key message that you take away, is the quality of the days reviews and developing of a smart recommendation that can be implemented within the existing health system. This is really crucial. I mean, I could speak an hour or more on just on this one, because one of the barriers where teams are discouraged and don't do MPDSR is because they don't see value in it. It is a same thing, a same recommendations every meeting. Nothing changes, and it is not doable. A number of barriers. So these are really key. So those reviews needs to be of quality. Once people have committed their time and come to review, then we have to make sure those are, we identify the causes appropriately, correctly, without blame, without shame. And also the recommendations also need to be smart. That means they need to be implemented in timely manner. The other point is monitoring. Then once the recommendations are done, it doesn't help if those recommendations are not implemented and make change in the way services are delivered or overcome the barriers system-wise or health worker-wise or patient-related issues that lead to the days. The whole idea of making the recommendation is, as I said, to prevent future diseases. The last 3 points are, improving perinatal days reviews by integrating with existing platforms. As we know, maternal days reviews have been going on in many countries. The platform exists in different maturity level. So perinatal days can be integrated. We have demonstrated that it can be done and it can be effective. Then, linking quality improvement to days reviews are really important and feasible. And the last point is, as you all have been pointing out in the chat, the blame culture and the support for the healthcare worker. The days that occur when that health personnel is attending is just one event in a series of events that lead to that days. So all that events and systems and needs to be looked at, and those that needs to be fixed needs to be fixed. So this is, our call for all countries that implement MPDSR to strengthen their system. So the next slide will show you, what would be the next steps. So we are working in all regions and the technical working group, the global technical working group with the donors and partners. We do have, a dissemination plan and also an implementation support at country level. All of, the partners that are engaged in this development are active in many of the low and middle income countries, and they are there to support. And as we are speaking also, many initiatives are ongoing. Soon you will be accessing this material at the WHO website. Many of you have been eager, and asking in the chat box how to find this material. So we will soon update, upload it in the WHO website and also in other platforms as well. So if you are interested to implement this, you can reach out to Francesca, who is the technical officer at WHO. Her contact address is there. And the next, I think this would be the last. Yes, the recording and the slides will be available at the Quality of Care website. And also you can visit, the Quality of Care website to find, other webinar series as well. We really, enjoyed your presence. Thank you for choosing among many other activities to attend this important webinar. And we hope you will find it useful. Many colleagues have spent so much wonderful time in developing this in the last 2 years. Thank you so much. Over to you, Olive.
Thank you for the final word. Tepev, that was fantastic. Thank you to all the panelists, all the speakers, and all the participants today. As the slide shows, we'll be sharing the recording and the slides. We'll also share the English translation, and we'll share the publication with everybody who was registered today. And for the questions, there were many unanswered questions. We would have loved to have had more time. So we will follow up to get answers to those questions, and we will also share them in a community of practice on the network website page. So we will communicate all of that information to you. Thank you so very much. Thank you very much. Goodbye.
Yes, thank you.